will bring up a few studies here for you to just be aware of. These are the studies that shape our thinking. Optimal medical therapy or guideline-directed medical therapy versus revascularization in stable patients. So a seminal trial, the COURAGE trial, published in the New England Journal. You see here more than 2,200 patients with stable disease, objective evidence of ischemia. Everybody got optimal medical therapy, but they were randomized to PCI or no PCI. The primary outcome was up to 5 years or 4.5 years, all-cause mortality and MIs. And there was no difference, which means that PCI did not improve death or MI. PCI may have improved symptoms. Patients who got medical therapy may have had more angina, may have needed more medicine, may have switched to the PCI arm because their symptoms didn't get better, but there was no difference in death or MI. That's very, very important. And that's the basis of that answer of the last question that we talked about. In the ischemia trial, there was some criticism of the COURAGE trial that maybe these patients did not have severe ischemia. They only had mild ischemia. Well, here they had severe ischemia or moderate to severe ischemia, and the conclusions were very similar. At 3 years, there was no difference in death, MI, hospitalization for unstable angina or heart failure or resuscitated arrest. So again, the same thing. In absence of left main disease, in absence of unstable angina, conservative or guideline-directed medical therapy is just as good as revascularization. We can skip this one. The Syntax trial looked at PCI versus CABG. So here is not medical therapy. Which is better, PCI or CABG? Well, it depends on the complexity of disease. So in patients with complex disease, as you can see here, the Syntax score defines complexity of disease. So in patients with intermediate group in the middle and the high risk group in the bottom, surgery is better for 5-year outcomes. For complex disease, PCI and surgery are equivalent for simple disease. Excel was a study for left main disease. It showed that, again, in simple left main lesions, you can use PCI. That's been a bit debated, so it's questionable a little bit, but probably true in simple left main disease. In diabetics in general with multivessel disease, it's very, very unlikely that you will find PCI to be superior. So in multivessel disease diabetics, the reduction in death and MI definitely is in favor of bypass surgery. We can skip this one. So these are the guidelines. In patients with unprotected left main, CABG is a class 1 indication. PCI is possible in patients, as you see here, 2A, which is possibly useful in patients who have simple lesions and not too much disease. In patients with multivessel disease, CABG is appropriate and beneficial, especially if they have proximal LAD disease. If you have single vessel disease, or if you have multivessel disease without involvement of the LAD, PCI is possible as well. And here, as I said, more than one disease amenable to revascularization, despite guideline-directed medical therapy, both of them can be accepted. This is a question here, final question. 65-year-old man, high blood pressure, referred for evaluation of chest pain. He got an angiogram here, and the echo showed an EF of 40%. So this is a quick tutorial on angiography, left main, LAD, circumflex, and you see a very, very complex lesion in the distal left main involving the ostium of the LAD and the ostium of the circ. So what's the best management here? Medical, assess viability, referral to CABG, or PCI? Excellent. So this is a very complex lesion. It's not a simple left main lesion. It's a very high-risk lesion. The answer is CABG. This is a diabetic multivessel disease. You see the LAD has a lesion, the circumflex has a lesion, and the right coronary has a lesion. So multivessel diabetic. So the clinical evidence and the guideline recommendations favor CABG rather than PCI in multivessel disease patients when diabetic, LV dysfunction, high Syntax score, or all of the above. You can answer. Excellent. All of the above. Correct. So this is why we use cabbage for diabetics, for LV dysfunction, and for high syntax or complex anatomy. So in summary, stable coronary disease patients management involves risk stratification with clinical evaluation and with stress testing. It's really important to get a good clinical history and a physical, and then a stress test would help with that. Treatment includes lifestyle modification, control of risk factors with pharmacologic agents, and with a lifestyle modification. Patients can be managed conservatively on medical therapy for a good amount of time. You're not taking away anything by withholding revascularization in patients with stable disease. As long as they're doing well, risk factors are under control, and their quality of life is good, you don't need to revascularize. We do need to consider PCI or cabbage when these patients have symptoms that are resistant to medical therapy. So remember, the treatment of stable coronary disease is primarily medical, and revascularization is left for select groups of patients only. Thank you very much.